Hi guys, welcome to this discussion where I'm gonna describe the 2021 update for the gold classification. First and the foremost, I'm gonna talk about MMRC, that is a Modified Medical Research Council grading of dyspnea. So just like in cardiology, you have a NYHA, New York Heart Association grading of dyspnea. In similar sense, we're gonna talk about the MMRC grading for dyspnea. So let's first compare grade 1 versus grade 2. Grade 1 is a diagnosed case of COPD who says, Doctor, I do not have problem when I'm walking on a level surface, but when he's going up an incline or when he's climbing stairs, that's when the breathing difficulty tends to come. Whereas when it comes to grade 2 dyspnea in an individual, he's gonna have problems even when he's walking on a flat surface. And I have told this COPD patient that, sir, you should go for a short morning walk. I mean, whatever physically his maximum capacity of morning walk is possible for you, try to walk as much as you can. So he's agreed to my advice, but he will always say that when I go for a morning walk with my wife, his wife is of the same age group as this particular chap. He is a cigarette smoker. He has had damage to his lungs. He has COPD. She does not have any medical problems like at the moment per se with respect to coronary artery disease or any ulcer in the sole of the foot. She does not have any osteoarthritis. She is physically fit, and when he tries to walk with her, he finds that he is walking slow as compared to her. He might even tell you that other people who are living with him in his society, they are of the same age group, let me say 65, 70 years of age. He says, as compared to other people in my society, I tend to walk relatively slowly. So the comparison here is obviously a bit of, I would say, can introduce a bit of bias, but the point is slow walking in this particular case, the comparison has to be done with other people of the same age group. We are not going to compare with, let me say, his grandson or his granddaughter who obviously can run and walk around. I am talking about another person of the same age group who is able to walk at a faster speed as compared to this person. And most importantly, he will also say that if I try to catch up with my wife, like she's walking ahead of him because she's walking relatively faster as compared to him, he says, when I try to catch up with her, I tend to get breathless. On comparison with grade 3, I would say that would be relatively easier to comprehend now. This particular person says, sir, I take 20 steps, then I feel so breathless that I have to stop intermittently and catch my breath. Once my breath becomes better, I again take 20 steps, then again stop. And I told him, sir, what you need to do now is walk 30 steps. He says, okay, sir, I will try. He will walk another 20, 22, maybe 25 steps because I'm motivating him, but he will just stop abruptly and will say, sir, it's not possible for me. I'm feeling so breathless that at the moment I want you to get me a chair quickly so that I can sit down and catch my breath. Or in some cases, the person might simply sit down on the floor itself or might sit down in the garden itself, and the person will say, I just can't take any further breath. So the message here is that when it comes to difference between grade 2 and grade 3 dyspnea is that in grade 2, he is still able to walk, albeit a little slowly, but in 3, he will just give up and he will keep on stopping intermittently. Whereas when it comes to grade 4 dyspnea, which is easy to comprehend, this person will be too breathless to go out. So I can say that this particular person will be having difficulty in even going to the bathroom by himself. He will have problems with even changing his clothes or even taking a bath by himself. The person will be wheelchair bound, or as I just mentioned, that the person is too breathless to go out. Now, why this is important for you is primarily because in the question, when he's gonna describe the severity of breathlessness in a person, the examiner expects that you are able to rate the patient on this MMRC grading of dyspnea, and on the basis of this I can say that now I can categorize the person as a low risk versus a high risk person. Let us take up a scenario where an individual who is suffering from COPD did not require any hospitalization in last 1 year, and he has breathlessness only on climbing or on going up an incline. This particular data that I have currently highlighted would be a person who will be requiring less number of drugs. I've called him a relatively a low risk individual and even having low symptoms. On the other hand, let's look at another scenario. Person required 2 hospitalizations in last 1 year. So because of repeated hospitalizations, I'm going to call him suffering from a high risk. And at the same time, his grading of dyspnea is also grade 2 or even higher, that he walks either slowly or stops intermittently or even is wheelchair bound. So this particular patient, I would like to categorize him as high risk. Why I said high risk? Because he was hospitalized. and high symptoms because he has difficulty in walking as compared to other people of the same age group. Why we are studying this is because the drugs which are available are limited. It is LABA, LAMA, inhaled corticosteroids and phosphodiesterase 4 inhibitors. But our decision which drug to be given, which drug not to be given will be based on a artificial categorization that we will do here. Like I will say low risk patient with low symptoms, or I will say a high risk patient with high symptoms. So let's just look at what the textbook says for I would say the COPD update 2021 guidelines, and also assisting you here will be another test that is called as COPD assessment test. Now COPD assessment test is, however, I would say having a lot of bias because it is a patient filled questionnaire. It will be dependent on the patient's interpretation, and if he is not educated then he will not be able to answer you, and even communication barriers can be there with respect to language issues because our country is so vast and diverse that different people would be speaking different languages. So when I ask a person regarding can you rate your cough from a grade of 0 to 5, or do you have any phlegm, or do you have any sputum, or do you have any chest tightness present, so I can say bias will be very much present in this score, but still it gives us an idea from the patient's perspective about how severe the disease process is. When it comes to COPD assessment test, there are total of 8 parameters which you will be evaluating the patient on, and I'll just zoom it in. This is to be filled by the patient. In fact, the person will tell you and the medical staff can just put a tick mark here, but you can understand a lot of bias can come up in a Likert scale. The maximum score possible here will be 8 into 5, that is 40. Minimum score will be 0, which will be obviously valid for people like you and me. And just generally speaking, if the CAT score, that is COPD assessment tool score, is more than 10, it definitely means that the patient has a problem. Now, on the basis of all this background information, I want to say that whenever you will read the GOLD assessment and then subsequently the GOLD classification, apart from classifying COPD as mild, moderate and severe, they will also categorize the patients as ABCD categories. Now, let's look at what he means by category A patient. This is a low risk patient. Why I'm saying low risk? Because he did not require any hospitalization in last 1 year. At the same time, his symptoms are also very limited. Only on climbing stairs, maybe one flight of stairs, he tends to have symptoms. Otherwise, he is perfectly fine. On the other hand, let's contrast this with a person who has been hospitalized 2 times in last 1 year, and he has difficulty in walking to the level that after 10 steps, 20 steps, he tends to feel breathless and stop intermittently. So I will be calling this patient as having high risk and high symptoms. I hope the point is clear. The risk is related to hospitalization. The symptoms are related to MMRC grading. And then I'll incorporate 2 more datas here. That is, you just need to remember it's going to be low risk, low symptoms, then it is low risk and high symptoms. So that's another end of the spectrum, that the person has not got hospitalized, but at the same time, the symptoms are relatively more based on MMRC grading. Now I'm introducing the opposite aspect. This is a high risk patient, repeated hospitalization, but at the same time, on a daily basis, the symptoms are relatively lesser. So based on this classification that we have made, we will be starting the treatment of our patient. So let's look at now, if it's gonna be a patient belonging to this particular category, which I said was low risk and low symptoms, then bronchodilators are to be given, and these bronchodilator can either be SABA or can be LABA. The basic point is you might be even going for a rescue therapy in these patients. Like you could be telling them that you need to use a bronchodilator when you tend to have symptoms, otherwise a regular usage of bronchodilator is not recommended. But when it comes to a upgrade, which I mentioned was low risk and high amount of symptoms, so we can be using either of the 2 drugs. Either it could be LABA, long acting beta 2 agonist, or it could be a molecule like tiotropium. So LABA or LAMA, either of the 2, it's either of the 2 that can be used. And most textbooks mention first, I would say, on a result basis. I mean, this obviously is not peer reviewed data, but on a comparison basis in most books, they have mentioned LAMA to be superior over LABA in these patients. Now, why I said this is not peer reviewed, or I would say is not a very validated fact, is because the perception of symptoms by a patient can vary. I mean, if a patient is saying that I'm feeling breathless, you really cannot grade how breathless he is, because for you as a doctor, you are relying on SpO2 values, fast breathing, Hoover sign, and other clinical parameters. But in spite of the fact that the person is having very minimal, I'm saying patient might be having very minimal evidence of distress. He might be saying, sir, I'm choking to death. So lots of bias can come here. But the textbook says that LAMA is first recommended over LABA. So I've just put a double mark here to say that if they ask you to select one, otherwise in the guidelines both are given. When it comes to, I would say a little more higher upgrade, that is categorization C, this would be a high risk patient. Here studies have documented LAMA definitely. So this is peer reviewed data. Here there is no confusion. So he has mentioned it categorically that studies have failed to show efficacy, though some studies have showed slightly more efficacy of LAMA in category B. For category C, he says it's well documented. It is LAMA tiotropium which is to be used. And why this is important is because if you have listened to me 2020 update, that is last year's app Preparator 3.0, you would have seen me talking about usage of steroids with respect to the categorization C. But now I'm saying that currently what is recommended is that inhaled corticosteroids are to be introduced when the categorization goes to high risk and high symptoms. In high risk and high symptoms, he says you can go for either of these two approaches. Either you can be going for combination of LABA and LAMA. It is and now, it's not or, it is and now. Or you can be using LABA plus inhaled corticosteroids. And then he mentions that the decision to add inhaled corticosteroids is based on the eosinophil count of the patient. Right in the starting of the previous video on COPD, I have told you that eosinophil count is used as a biomarker of COPD activity. If the eosinophil count in a multiple choice question or in clinical practice is turning out to be more than 300 per microliter, then inhaled corticosteroids will definitely show benefit in this patient. I want to highlight that this particular information is the most important reason why I am describing this particular video, or why I have updated this video, because as compared to the last year where inhaled corticosteroids were mentioned for C, now I'm talking about a category D, high risk and high symptoms, where ICS, and they've also mentioned importance of eosinophil count for these patients. Over and above this, I also want you to remember that if eosinophil count in a COPD patient is lesser than normal, it indicates the fact that the risk of development of pneumonia, this is just a statistical information. I mean, there's no logic behind it. It's just that it's a statistical information that we've documented. The risk of pneumonia is increased. Apart from this, another update that they mentioned is that test all diagnosed cases of COPD. The definition of COPD I've told you is any person who's having a non-reversible airflow obstruction with FEV1 FVC ratio less than 0.7 in spite of bronchodilator administration. He says test all patients now for alpha-1 antitrypsin deficiency. Why that's so? Because now we have treatment available for alpha-1 antitrypsin deficiency, which is that we can give these patients weekly injections of alpha-1 antitrypsin, which is manufactured by DNA recombinant technology. So the test that you will write for your patient will be serum alpha-1 antitrypsin levels. Another update is that the vaccination of these patients should be complete. COVID-19 vaccination is anyway to be done. Pneumococcal vaccine is anyway to be done, but is also mentioned regarding acellular pertussis vaccine. I want to highlight this statement. Apart from COVID-19, pneumococcal influenza, even pertussis vaccine should be routinely given to all patients of COPD. And if cost part is a consideration, then from, I would say, Indian perspective, at least geriatric patients of COPD should definitely be given a pertussis vaccine. Other vaccines I'll just mention here that you are very well aware of. That would be influenza vaccine. By nasal route also it can be given. Then is the polyvalent pneumococcal vaccine, and COVID-19 vaccination course should be completed in these patients. I have already sensitized you to the fact that alpha-1 antitrypsin is available because of the DNA recombinant technology, and the term that will be used to describe this will be written as alpha-1 antitrypsin augmentation therapy. The injections are obviously expensive, so either medical insurance of the patient, or let me say, the person will have to, in India, will have to fund it by himself. The number one cause of lung transplantation in the world is idiopathic pulmonary fibrosis, but after idiopathic pulmonary fibrosis, emphysema/COPD is one of the important reasons where you will have to go in for lung transplantation in selected cases. Now, alpha-1 antitrypsin deficiency, the problem is not that it is not being produced. When I say deficiency, it basically means production is there, but the release from the liver is defective. And alpha-1 antitrypsin is supposed to neutralize the elastase, which is released from the alveolar macrophages. And if this neutralization is not there, then this elastase will cause damage to lungs. And therefore, the person will be having a pan-acinar emphysema, whereas for cigarette smoking, I discussed it was centracinar emphysema. Now, while I have written this data, you guys can quickly comment regarding what chromosomal defect, which chromosome is involved in development of alpha-1 antitrypsin deficiency. And genetics is the in thing nowadays. So I'm just gonna incorporate the genetic locus also, which is written as SERPINA1 locus, and is also written sometimes as PI, protease inhibitor. Yes guys, I was waiting for answer. The chromosome involved for alpha-1 antitrypsin deficiency is chromosome number 14, and then there are various alleles with respect to this genetic locus, which would be written as M allele, S allele and Z allele. Now let's look at the importance of this. Lots of time you will read in multiple choice questions word written like PI, that is protease inhibitor. That's an alternative name for SERPINA1 locus, and then there will be a superscript that would be present, like it might be written PI superscript M or PI superscript S or PI superscript Z. If you read the word M allele, it means that everything is normal. Alpha-1 antitrypsin levels are normal. Genetic locus is working fine. If you read PI superscript S, it means levels are less. And if it is gonna be Z, that implies that the levels are severely reduced. And in these severely reduced patients, I was talking about augmentation therapy utilizing the DNA recombinant technology. From your pathology classes also, you would be aware of the fact that every time he writes the word PI superscript Z, this should be written or remembered as the most common form of severe alpha-1 antitrypsin deficiency. So a bit of genetics here, and I think that they can mix this with pathology. So it's always a good idea to remember this information. And alpha-1 antitrypsin in these patients, because it will not be excreted by the liver, it's being produced but is not excreted by the liver, so it will accumulate in the liver. So person will end up with development of liver cirrhosis as well. Additional information that I would like you to remember is that you always will read in multiple choice questions of lung cancer and chronic bronchitis and even bronchiectasis sometimes word pack years. So how do we calculate pack years of cigarette? It would be simply that one cigarette pack would be having 20 cigarettes. That's standard. So it is number of cigarettes a person is smoking per day. Let us assume a person is smoking 40 cigarettes a day. And the denominator here is 20 because, as I said, one pack is having 20, and you need to multiply this by the years of smoking as claimed by the patient. Like for example, I'm saying a person is smoking 40 cigarettes a day, so the pack years will be calculated by you as 40 by 20 into 10, which will mathematically work out to something in the range of about 20 only. Just mathematics is what I wanted to highlight for the word pack years. Then another parameter that you will again read in multiple choice questions of COPD can be BODE index, BODE. This BODE index is used to predict mortality. Now, if a person is suffering from COPD, if he is already having polycythemia, is having right ventricular hypertrophy, pedal edema, then mortality will definitely be higher. So instead of using single parameters to predict mortality in COPD, they have combined 4 parameters together in the BODE index to determine the chances of survival versus the death of this person. So in the BODE index, the first parameter would be body mass index. As I told you, in COPD, the person will tend to become obese, and anyway, anybody having hypoxia, physical activity will be less. So he might keep on eating, and if there's no physical activity, weight gain of the person would be present. Then is the value of FEV1. Anything less than 30% would be counted as very severe. Then we'll look at MMRC, grading of dyspnea. I've already explained to you that grading of dyspnea would be, I hope you can recall, problem with going up an incline, 1, walking slowly, 2, walking slowly and stopping intermittently, 3, and if it's going to be wheelchair bound, it just refuses to go out, that would be grade 4. And then is a 6-minute walk test. I mean, you would simply ask this guy to walk, from point A to point B. You can measure the distance between the 2 points and then ask him to continue walking for 6 minutes duration, and he'll be able to walk a few hundred meters. So based on these 4 parameters, the board index is calculated. The question will simply say board index is used to determine or is used to predict mortality in cases of, your answer would be COPD, and these are the 4 parameters which are to be remembered. And I've just highlighted a couple of updates like the vaccination aspect and also testing all patients. Now obviously, you'll understand that from an Indian perspective this might be I would say beyond the reach of routine patients and routine hospitals, because testing is anyway expensive. But though alpha-1 antitrypsin constitutes hardly 1 to 2% of all cases of COPD, these are the guidelines now to test all the patients. So I thought I'll just mention that before you. And an additional fact was eosinophil count. I mean, increased is a decision maker for steroids. And if it is lesser, anyway, incidence of pneumonia has found to be higher. So these are the details which I want you to remember for this table. And this particular part of the slide that I highlighted, especially with respect to categorization C versus D, the differences from 2020 is one of the fundamental reasons I made this video. So thank you so much for your patience and hearing me out. Keep learning, guys, new facts, and you will be definitely through with your exams.